I'm Emma Storey, Neurology Cases GP, and I'm with Phil Storey, Consultant Orthopaedic Hand and Wrist Surgeon. Thank you for taking the time to chat to me today about carpal tunnel and cubital tunnel.
Very welcome.
So to start with, can you quickly remind us of the classical presentation of carpal tunnel syndrome?
So it's pins and needles, paresthesia, numbness, pain in the median nerve distribution. It can radiate up into the forearm, even as far as the neck, anywhere really where the median nerve passes. And most commonly, the symptoms start with nocturnal tingling, pins and needles, numbness, feeling of a large hand, which may present as waking from sleep first thing in the morning with those symptoms. There are certain vocation activities, including being on the phone, raising your hand above your head, and this progresses sometimes to permanent tingling, pins and needles. That's when the sensory branches of the nerve are involved. Further progression can involve the motor branches, where there is loss of dexterity of the fingers and weakness of the median nerve muscles, particularly the ones in the hand. The abductor pollicis brevis, which, if you imagine putting the back of your hand on a flat surface and lifting your thumb up towards the ceiling. If the examiner then pushes down on the tip of the thumb and feels on the thenar muscles, you'll feel the abductor pollicis brevis. It should not be possible normally to overcome a patient trying to keep their thumb in the air. If the examiner can overcome it, then there is some weakness of the abductor pollicis brevis. This is mostly 100% supplied by the median nerve. There are other provocation tests which are useful, Tinel's test and Phelan's test, which I'm sure. These may be negative if a patient has permanent and tingling in their fingers, but if it's intermittent, they may start the symptoms the patient will recognize as the symptoms they get during the night or when they're on.
So if the diagnosis is obvious, we've got the Sheffield carpal tunnel syndrome pathway to follow, which would involve a carpal tunnel syndrome score and conservative management. What would that entail?
So to my mind, that's really involving splints. So the concept is that the Futura splint, which has an aluminium bar on the volar side, on the side, they're often bent back slightly. Principle is that if the wrist is kept straight, then the space around the median nerve is maximal. If the wrist is bent or the wrist is extended, the nerve is tented over the bony or ligament line around the carpal tunnel. So clearly you want to try and keep the wrist straight. Now, the Futura splint, it's bent back slightly to keep it in the position of safe immobilization. You don't want that, you want this to be straight. You can take the bar out, straighten it, and put it back in, and then the patient will hopefully less symptoms because their nerve is being less compressed. The other options obviously may be anti-inflammatories or analgesics. If there's a known cause for the carpal tunnel, for example, inflammatory joint disease, or even arthritic joint disease around the base of the thumb, then treating that may help symptoms of carpal tunnel syndrome. The diagnostic injection, which is obviously partly therapeutic as well, should only be given if you've been trained to do it.
And so are there situations when we would refer rather than treat conservatively?
Yeah, definitely. So if there's any case of a patient with weakness, APB wasting, elderly patients with permanent symptoms do not do well unless they're treated surgically. They won't respond at all. Obviously, the nerve is fairly fragile already, as it's an elderly nerve. Has an insult, then it will really need surgical management to settle the symptoms down. Elderly patients really don't tolerate carpal tunnel syndrome at all well. So kind of almost against what you might think, these are the people that we really need to see. Anyone with wasting or anyone with permanent symptoms that have not settled through a short trial with conservative management in a splint patients.
And if we notice wasting, is that going to affect the triage urgency that you?
Yeah, definitely. So interestingly, we do triage nerve compression above arthritis. Patients are referred to the hand centre, so they're already on a more urgent pathway. If there's APB wasting mentioned prominently in the referral, then that would make it even more urgent.
So that's great. So, but often people come and see us with less clear-cut symptoms. So maybe pain in the forearm, whole hand might be numb, bilateral symptoms. What would you recommend then?
So I don't think bilateral symptoms is a differential, but it's certainly, if the pain is not classic in the median nerve distribution, if it's not really pins and needles, if it didn't have a classic start where it was a bit nocturnal to start with, a bit intermittent, it just doesn't quite fit with your experience of carpal tunnel syndrome, I would have a low threshold for arranging nerve conduction studies. There are many other causes of nerve compression, obviously, including diabetic neuropathy and alcohol-related neuropathy, soft tissue disorders, vibration white finger, compression coming from the neck. If these are in your on thought processes, then it's well worthwhile arranging nerve tests to further delineate the diagnosis.
So bilateral symptoms doesn't necessarily point you away from.
No, it doesn't. It's very common that people have bilateral symptoms. It's often that one side is worse than the other. It's very common that I'll decompress the staged procedure, both sides of people carpal tunnel.
So what are the differentials?
Okay, so we mentioned a few already. One of the things that I haven't really mentioned is double crush phenomena. So it's quite possible that someone has compression of their median nerve that comes out of the neck, be the actual nerve, but the fibers that end up being the median nerve. So it can be compressed at any point along the pathway. So it can be compressed in the neck, in the arm, as it comes through into the forearm, and then as it passes through the carpal tunnel. So nerve tests would help with that. If there's double crush phenomena, even if the spine is probably the thing that you think is the most likely thing, it's well worthwhile us seeing the patients to assess through nerve tests. And if they do have a positive finding of carpal tunnel syndrome, even though they may have a radiculopathy, it's a lot easier to treat carpal tunnel syndrome than C-spine compression. Therefore, it's very common that we receive referrals from the spine surgeons. The patient has compressive neuropathy in their neck, but also carpal tunnel syndrome. Would you please deal with their carpal tunnel syndrome first? And if their symptoms settle enough that they're happy, then I don't need to perform any dangerous surgery in their neck. Makes sense, doesn't it? Deal with the easy thing first.
And are there things that would make you think a neurology referral will be more useful for some patients?
Yeah, it's quite tricky, this, isn't it? I mean, if it just doesn't fit, I suppose, if there's peripheral neuropathy elsewhere, so if the feet are affected, if they have family history of a peripheral neuropathy, clearly. Interestingly, I think diabetes can coexist with carpal tunnel syndrome, and also carpal tunnel syndrome isn't necessarily a familial disease, but does seem to run in families. So difficult one. I think unless you're really sure it's not carpal tunnel syndrome, I would send it to MSK rather than neurology.
And what should we tell a patient to expect when we refer them to you?
Brilliant. So if there's any doubt in my mind whether it's carpal tunnel syndrome, I would arrange nerve tests. Sometimes I just do it anyway, just almost as a way of being able to tell the patient how severe their symptoms are and the likelihood of recovering from an operation. It's better if the nerve tests are not severe. So they will probably have nerve tests. They may have an injection. So the injection can be can help with the diagnosis, but it's also therapeutic too. They give several months of reduced symptoms. If they are listed for surgery, they'll have a local anaesthetic operation, which involves an injection around the wrist into the hand. It's very painful. They have a tourniquet, which is inflated to about 250 millimeters of mercury, so it's tight and will be up for about 10 minutes. The operation should not be felt. They'll have a nylon sutures put in, which will need to come out about 10 to 14 days. A big bulky dressing. Their hand, they will be able to move their fingers and use their hand, but they need to keep it dry and clean. They should not remove the dressing from the time that they have surgery before they have their stitches taken out, which often is done at the practice nurse GP practice. They're able to continue to move their fingers as soon as they come out of the dressing with the stitches taken out. Need to massage their scar, try and reduce scar sensitivity. Pillar pain is extremely common. It's due to the fact that the ligament holds two of the bones in the palm together, and we'll do the decompression. We cut that ligament. It takes several weeks for that ligament to heal with more space underneath it, so the nerve's not pinched. But that ligament instability, every time you push your palm onto a hard surface, it's extremely painful until it's healed. So you can expect to have pillar pain. Patients usually say that the tingling and pins and needles gets better straight away, but occasionally it does take several weeks, probably due to severe damage to the nerve regrowing along the path following the compression being removed.
And then lastly, cubital tunnel syndrome is much less common, but can you just briefly about that?
Sure. So instead of the median nerve, this is the ulnar nerve. The ulnar nerve passes down the arm and around the elbow. The olecranon, which is the bony bit at the point of the elbow, and the medial epicondyle is the funny bone, the bit on the inside of the elbow. There's a little tunnel between those two. You can feel it. The ulnar nerve passes there, passes down the forearm and supplies the little and ring finger with sensation and most of the small muscles of the palm. When it's pinched around the cubital tunnel, it clearly has tingling in the distribution of the supply of that nerve and wasting of the small muscles of the hand, again presenting with loss of dexterity. The Tinel's test is positive around the elbow. It's tapping between the two bony bits, and sensation is felt in the distribution of the ulnar nerve. The small muscles are probably best tested with resisting spreading the fingers apart, and Froment's test, which is perhaps a little bit more complicated, but involves a piece of paper and pulling down the thumb, the index finger. You'll have to look that up in the textbook. It's impossible to explain that through a podcast. Crossing the fingers and opening them is another little test to do. In terms of conservative management, there isn't really any conservative management for cubital tunnel syndrome. Some people talk about nerve glides, but there's not really great evidence for that. Sleeping with the elbow straight would be a potential solution if it's nocturnal symptoms, but obviously it's very difficult to know where your elbow and your hand is when you're asleep. So trying to get a patient to sleep with their elbow straight would be about the only thing you really do. Splints don't work, not well tolerated. So I always do nerve tests for cubital tunnel syndrome. You can arrange those beforehand. That would be brilliant. And just occasionally, patients have a subluxing ulnar nerve. So they have, when they bend their elbow, the nerve is tightened clearly and flicks around the medial epicondyle. They may present with normal nerve tests, but very symptomatic, classic cubital tunnel benefit from operation.
That's great. Thank you very much for your time.
You're really welcome.